Hello everyone and welcome to another QIP webinar. Today we're talking about the National Safety and Quality Primary and Community Standards with Margaret Banks, Director at the Australian Commission on Safety and Quality in Healthcare. We acknowledge Aboriginal and Torres Strait Islander peoples as the custodians of this land, and we pay respects to elders past and present, and commit to a future with reconciliation and renewal at its heart. We recognise the concepts of land, family and spirituality are directly linked to Aboriginal and Torres Strait Islander people's physical, mental, social, spiritual and cultural well-being. We would like to recognise that Aboriginal and Torres Strait Islander peoples and communities continue to experience poorer health outcomes than any other Australians, and that these inequalities must be understood within the historical context. Before we get started today, I'll quickly run through some details relating to this webinar. Firstly, our live webinars are being recorded and will be uploaded to the QIP Accreditation Hub for access at any time by you or any other members of your team. In relation to the content covered in this webinar, we'll endeavour to answer your questions at the end of this session, and due to time constraints, we'll try to address any unanswered queries in upcoming QIP communications. Now, to ask questions during the webinar, click on the orange arrow button to your right and type your question into the question box, similar to what you can see on the screen. And once again, it's my pleasure to welcome Margaret Banks, who's worked as the National Standards Program Director with the Australian Commission on Safety and Quality in Healthcare since July 2006. In this time, she's worked with stakeholders, consumers and jurisdictions to develop and implement the National Safety Quality Health Service Standards and a program of systematic accreditation reforms across the Australian healthcare system. Thank you for joining us today, Margaret.
Thanks very much. So it is good to be here. This is an area that is new and growing, and I expect that you do have a number of questions. So what I'll do is, next slide, thanks, is to give you an overview of the standards. We'll focus on those things that are different here for those that know the national standards. We'll talk about the transition processes that organisations are going through, resources, and then happy to have any of your questions as we go on. Next slide, thanks. So the standards themselves were launched in October 2022, so very new set of standards. They were developed after an extensive period of consultation, and I would say years of consultation, probably from about 2014-15 when we first started to talk about this. They've been developed in consultation with the sector and are applicable to services that deliver healthcare in primary and community settings. So then they're non-acute outpatient setting, the ambulatory settings primarily. There's 65 actions that span across 3 separate standards. The first 2 standards provide a framework for safety to embed and continuously improve clinical governance by providing a clinical governance framework, and when put in place, should provide a robust set of systems that minimise risk to patients. The third standard is a clinical safety standard, which address those commonly encountered safety and quality risks in this sector, and they've been written and designed specifically for primary and community care. It recognised that the applicability of standards is extremely broad, so the types of primary and community services, their size, complexity and risk is very different across the sector, and that there are 10 actions in here that may not apply to all settings. So for some organisations, they just that don't do medication may not apply at all. So it is somewhere between 55 and 65 requirements, described requirements in the standard. Thank you. Next standard. Next slide, please. And so if you look at these standards compared to other standards, the Commission writes standards with the same format, and that's because we believe that the clinical governance framework that sits up front is the foundation piece of any safety and quality system. So in the primary and community healthcare standards, while they're aligned to the structure and the intent of the national standards, they support health services to develop individualised clinical governance frameworks, but in a setting and relevant to the context in which you're working. Both sets of standards were written from the perspective of the patient, so they are central to the way that the standards are structured. The language and actions in the primary and community healthcare standards, though, have been adapted to the context because you don't have large and complex organisations generally. All of the other standards, so underneath those standards which represent the high risk areas in an acute setting, of which there are 6 in the national standards, have really been reviewed and incorporated, all the elements of them that are important, incorporated into the clinical safety standard, except blood, because really that's just not an area that is common in the in primary and community healthcare. So the actions have been streamlined and tailored to the setting. They're proportionate to the risk and the potential for harm for patients, and not only the potential for harm, but the consequences of harm. Where the consequences in a hospital where you have surgery, that the consequence is substantial, the consequences of harm of in a primary community health care setting are likely to be significantly less. Many of the risks associated with acute sector that relate to inpatient care are just not required in these sort of standards, and most presentations in the sector are not urgent, life or death situations, and so this is reflected in the language and the expectation on primary settings, primary and community settings. Consequently, there's only 65 actions, not 151, as there are in the acute services standards. So if you go and we talk about each one of the standards in turn, the clinical governance standard covers things like the culture of safety and quality. Now, that's really saying, do you use the information, collect information so you know how well your organisation is performing, and do you have a culture whereby people who, when a mistake is made, learn from it and make changes in the organisation? And that's really what we mean when we're talking about safety and quality culture. Do you have the policies and procedures in place? And they don't have to be complex, but you do know what it is that is intended to happen in certain situations. And policies and procedures should really only be written about those things where there's a risk of harm, and so that you minimise that risk and everybody knows how and what's the process for minimising those risks. You have a system for collecting information when something goes wrong, so when there's an adverse event, and to collect feedback, because feedback from both staff and consumers are a really good way of understanding potential safety and quality issues. Complaints is also another mechanism. Health records are both a legislative and regulatory requirement, but they're essential for providing safe care, recording treatment and managing the person's progress. Understanding who you're providing care to is important because groups of people, so older people, people with disability, Aboriginal and Torres Strait Islander people, other groups also may very well have be facing specific risks that you could minimise in the way that you design your services or provide your care. Understanding that your staff or your workforce have the right skills and qualifications, that they've got the training to actually provide the care that's being delivered in your service, and that when you deliver care, you use the best available evidence and guidelines to make sure that you do. And where you're doing things that are not in line with guidelines, there's a reason for it. There's a preference of the patient, or there's a clinical reason, and where there's variation that's unwarranted, and you reduce that, because in reducing that, you reduce the likelihood of harm. And the last one here is about safe environment, making sure that where you're providing care is both safe and private and free from infection, for example. When we look at there's one thing in here, in this standard, there's one action that might not, or two actions that might not apply, and they relate to the My Health record. While this is a long-term objective and a priority area for the Department of Health and the federal government, It is an area where we recognise that in primary and community healthcare there are still barriers to being able to upload and to access this information. So for organisations that are, or practices that are not using My Health Record, these may be two actions that don't apply in your setting. The next standard then, please, in the next slide, talks to how we engage and involve consumers in care. And we know from the evidence that engaging people in their own care improves the outcome, because they, in understanding what they're intended to do, what's their part to play in improving their own care, they can better make informed choices and engage in the treatment regimes. So the first part of this standard is all about how you involve a patient in their own care. The second then is about understanding that they have rights in that care, and there's a My Healthcare Rights, which is about access and safety and respect and privacy, and making sure that providing information in a way that people can make informed decisions and give informed consent to treatment protects you and it protects them. Communication and information, because we know in Australia the average 6 out of 10 people have a very low health literacy level. That means they don't understand when you give them information about their own care and about their own treatment. So if they don't understand, they can't give informed consent, they can't participate in their own care. So the way that we give information and ensure that they understand is crucial, and that's why that's in the standard. And the last part is making sure that we incorporate the views of people in the way that we deliver and design services, because they are the one group that have treatment at all places, and they are the one group that have a legitimate input into how you experience the care that you deliver. And so incorporating their view into the way you provide care. Finally, the next standard, which is the clinical safety standard, next slide please, talks about the sort of things which are traditional safety and quality issues and may or may not apply in every setting. So prevention and control of infection is essential. And that's, in these settings, the sort of things that you would expect to see, making sure that people are washing hands and not transmitting infections. You're using standard precautions so that you assume that people may have an infection and that you're preventing the spread of that both to your staff and to other patients. So there's some minimum expected prevention measures and control measures that you would have in place. Medication safety, where you're using medication. So if you are not, then clearly this standard is not going to apply. Comprehensive care is talking about how you would provide screening and assessment to make sure that when you plan and deliver care to whatever patient is appropriate care. And so this is really using the systems that you've set up in the second standard for information and sharing information and undertaking assessment, and then managing the specific risks that a patient might have because that you've identified during your screening. And then to recognise when a patient starts to deteriorate, have a way of escalating care and responding so that you minimise the harm. And unlike in an ICU where deterioration may happen very quickly, in a primary and community healthcare setting, the deterioration may in fact be slower, but still recognisable. And there is certainly action that can be taken to minimise harm. And in this standard, there are a larger number of actions that could not be applicable. So for 3 of them, where you're not doing anything that's invasive, you won't be doing aseptic technique, you won't have to use invasive devices, and therefore you won't be using sterilising and reprocessing equipment. That doesn't say that you won't keep a clean environment, but you won't need to use any of those. Where you're not prescribing antimicrobials, then you don't need an antimicrobial stewardship program. And where you're not managing, handling, administering, prescribing medicines, then there's another set of standards that won't apply. And for many community and primary care services, end of life is not a component of the care that they provide, and so that also wouldn't apply. So when we talk about these standards, what's new, the sort of things, next slide please, the sort of things that are specific to primary and community healthcare that are important here relate to patient safety and quality systems, the healthcare record, the way that you have your healthcare records. Because you collect information from a range of other providers, such as patient referrals, medication reviews, pathology or diagnostic imaging results, that can be critical to the component to determining the course of action of a patient's healthcare and their treatment. You want to ensure that healthcare services have established processes to review, act on and document reports on a patient's care to minimise the risk of harm and loss of information, which can result in misdiagnosis and harm, or just not providing the care that's required. And this should include processes to receive and action urgent reports. So that's what this action is primarily about. The next slide, please. The next one is about the safe environment for delivering care. This recognises that supporting patients to access your health care service is fundamental to delivering safe and high quality care. Support should take into account the relevant feedback from patients, as well as consideration of the patient population that historically faced barriers to access. So the Royal Commission into Disability is a really good example of people with disability being unable to access services physically because of ramps, stairs, railings, but also because information is not available about the sort of services that they provide. So your health care service can support patients to access care by understanding the barriers and challenges faced by patient populations and making changes to mitigate those changes in your service. Next slide, please. So the next one's about health literacy, and I've spoken about this in terms of a nationwide problem. So 60% of people don't understand when you talk to them about their care. So providing access to information about your service will help consumers decide when, how and whether to use your service. Access details can refer to physical access or remote access if you're using telehealth or some other virtual care. Where the same service is provided from multiple different sites, access details to each of the sites should be provided. Where services are provided in a patient's home, access details are not required, but you need to explain that that's how the service is delivered. So it's about when, where and how you deliver that service. And this sort of information needs to be available. So do you provide after hours service? And if not, where should your client base go to for that care? In relation to clinical standards, clinical safety standards, so the next slide, please. This is an additional infection control standard that's been tailored specifically for primary care because it relates to respiratory hygiene and coughing etiquette. This is the most likely sharing of infection that's going to happen in a primary community setting. It refers to the infection control precautions of covering sneezes and coughs to prevent infectious persons from dispersing respiratory secretions into the air. Hands must be washed with soap and water after coughing, sneezing or using tissues, and after contact with respiratory secretions or other objects containing any of these secretions. Physical distancing, we all now know about much more than when we started writing these standards, but they're evident now, and refer to the practices of maintaining distance, usually 1 to 2 metres between yourself and others. And I think COVID has brought this into sharp relief and the importance of this. The next slide, please, talks to comprehensive care. And this is really the role of primary and community care has had a greater part in health promotion and prevention than any other setting, but it occurs in basically all settings. Healthcare services are encouraged to support health, education, promotion, illness prevention and early intervention in the areas of clinical practice and tailor their message to the specific patient populations that you have. For example, podiatrists working in community have high rates of type 2 diabetes patients, or community health services working in areas with large Aboriginal and Torres Strait Islander people will present prevention and promotion messages opportunistically, but in different ways to others. So this is really trying to promote and encourage opportunistic prevention and promotion activities. Next slide, please. In relation to communicating for safety to maximise patient attendance, we know that effective communication with patients about their appointments can maximise their attendance and support more informed management. Once planned communication processes to maximise patient attendance at appointments may include things like ensuring the appointment details have been communicated with the patient in a manner that meets their needs and preferences. So if there's opportunities to provide email confirmations, text follow-ups, include support workers, carers or a nominated contact or communication about planned appointments, so that if you were dealing with children, people with poor levels of English, anything else that allows you to use the family supports or carer supports that support them. Liaising with other healthcare providers involved in the patient's care, such as the general practitioner or care coordinator, to identify opportunities for patients to attend. Considering opportunities to extend or vary operating hours so that people can access the care. Adopting a flexible rescheduling or cancelling policies, so that might be online, and allowing people to pick up appointments by searching your site. Ensuring the healthcare service provides a safe and welcoming environment for different patient populations, and particularly evident for Aboriginal and Torres Strait Islander people, where cultural safety is a key part of accessing a service, and providing a reminder services to patients either by phone, email or SMS. Next slide, please. So how organisations can transition. If you're assessed already against a set of standards, there's a process where you can move, and that's all been described in a transition fact sheet. And it talks to those things that you would need to do about signing up with an agency, conducting self-assessments and undergoing an assessment process. However, if you've never been accredited before, and this is a new area of endeavour for you, there are staged approaches to accreditation. You can start with desktop assessment, which is largely a document review to allow you to get in order all of those systems and processes to collect, monitor and manage your risk and information. You would be allowed under the scheme to stay on that desktop assessment for a couple of cycles, shorter cycles, and then you would move into either a virtual or an on-site assessment, which would mean that people come in and look at your processes and how you provide services, and give you what hopefully is not only information about areas for you to improve, but give you an idea of things that you might be able to do more effectively to improve the safety and quality of the service that you are providing. We know, next slide please, to be able to implement this, that you need some support, and so the Commission has developed a range of services, resources that are available on the Commission's website, both a monitoring tool to do your self-assessment, a guide document. Now that has just been signed off by our board, but there is a draft document on the website. The final one will be up by the end of this year. There's fact sheets that talk about your transition, but also lots of information in various parts of the Commission's website around informed consent, about patient rights, about open disclosure, and all of that information is available on the website. Now, if you're unable to access or still have questions and they don't answer them, then next slide, please. We run a couple of things. You can go to the Commission and email us directly, or you can speak to the Advice Centre, which we operate on business hours 5 days a week. You can call or email. If we can't answer your questions, we will go and find experts that can help you, or you can talk to our manager of the Primary and Community National Health Standards, Christina Lane. So there's the Advice Centre, who just for queries, if it's technical and specific, then we can chase up some advice for you and some support. But that operates and is available for anybody putting in standards, any of the standards that the Commission's involved in. And so really that's a short and overview of the standards. I'm happy to take any questions if people have them.
Thank you, Margaret, for that very concise description through the national standards, National Primary and Community Healthcare Standards. Now, a few questions were actually submitted prior to the webinar by people who unfortunately weren't able to attend, so they've actually just emailed them through. One question was, which types of services would you encourage to undertake the PCHS?
Okay, so these are services that provide any sort of primary and community health services. So I know that in the public sector, all of the drug and alcohol, the dental practices, the community wound management programs, the palliative care ambulatory services, the outpatient, they're all moving to primary and community healthcare services. In the private sector, I would anticipate any of the allied health services or community-based services could move across and use these standards.
Yeah, perfect.
We nursing-led practices, well, nurse-led practices in Victoria, all of the bush nursing practices are moving to these standards. So, you know, it's quite a broad spread of service types.
Yeah, and we actually have a few of those in attendance at the moment. Nurse-led or nurse practitioner-led clinics. Another question that was submitted prior was, what sort of resources do you see are required for virtual assessment? Now, I take it that they're asking on as a service provider rather than as the accreditation provider.
Yeah, sure. So if you're a service provider and you're thinking that you will be assessed, you'll need some way of the assessing agency seeing your organisation. So you'll need adequate Wi-Fi. You'll need a piece of equipment that's mobile, so a laptop with a camera, an iPad with a camera, even a phone.
Yeah.
You'll need to do some planning, and we've done some fact sheets on actually setting up and all of the things that you need to know and think about before you do your assessment as a service doing virtual care. And there's a number of fact sheets on the website that might help you. But certainly you need to have sufficient IT capability and Wi-Fi to be able to actually walk around and see the service and see the whole service. It's no good if the Wi-Fi operates only in you know, the main rooms. If the whole service operates over a number of campuses or over a number of spaces, then you would expect to be able to see in all of those spaces.
Yeah, and it's good that you also mentioned obviously mobile devices like mobile phones. Typically they'll always be connected. So if you do have those sorts of Wi-Fi challenges, as you know most people do, a mobile phone or even hotspotting a mobile phone could also be an option. Just in relation to virtual assessments again, is there a difference in recognition for virtual and or desktop assessments?
Look, if we start at the the bottom end, desktop assessments are the least rigorous way of doing an assessment. So you will be less out of them as a provider, because the accrediting agency is not going to be able to say, well, look, you know, you could do this differently, because what paperwork does is tell you what you should be doing. It doesn't say what you are doing, and it's not until you observe someone's actual practice and you talk to people that you can tell what is actually happening.
Yeah.
So if you're doing virtual assessments and you're able to talk to the workforce and see the area in which they're providing care, and talk to consumers as well, then you get a much better idea of what's actually happening. And it's the difference between what should and what is actually happening, the area where you can make improvements.
Yeah. We have found that a number of organisations who've been hesitant to achieve accreditation in the past because of staff changes or whatnot, they've are looking at and considering the desktop assessment as kind of dipping their toe and getting the organisation involved in that sort of change, and then looking at obviously the virtual and with ambitions to do the on-sites in future assessments. So, but yeah, I do echo your statements there around actually getting the proper value out of it. In terms of recognition, though, I believe the certificates will actually have that noted that you've gone through the various methods.
That's correct.
Yeah. Now, just another question that's just been emailed through to me. And in terms of the, I think they've just clarified, recognition for virtual or desktop, is there a difference in timeframes? And the short answer is yes. Timeframes for accreditation cycles.
Yes, there are. So a desktop assessment, you get a 2-year cycle. With the on-site or virtual assessment, it's 3 years.
Okay, perfect. Now, great. So it looks as though we've actually had the questions that were asked in the chat actually already answered in prior. Is there any other points that you'd like to leave people with in relation to the primary community healthcare standards?
Look, I think that regardless of whether you're accredited or not, they provide you with a framework for safety and quality. Understanding the standards and thinking about them in relation to the service you provide is the first step. The accreditation provides a level of trust to the system, to consumers, to patients, that the service that they're going to get has it considered and is minimising the risk to them, and therefore their trust and is going to be greater. So there's value to the service for being accredited, but that only happens once the standards are implemented, you know, because it's at that point that you are in fact an organisation with a robust clinical governance framework in place, and an organisation that's monitoring and reviewing and looking at its risks and managing its patient care. So I guess I encourage you to look at the standards and see how you might be faring against them, and then consider the value of accreditation going forward.
Yeah, fantastic. Thank you for that, Margaret. Now, doesn't seem to be any other questions coming through on the chat, so I really do appreciate your time. If anyone ever needs to reach out to you, the details were provided, to the Commission. The details are provided in prior slides. And once again, this webinar is recorded and will be available on the QIP Accreditation Hub. But thank you so much for your time today, Margaret. I understand how busy you are juggling multiple frameworks. So thank you very much for your time.
You're welcome.
Now, if you are an organisation that is interested in becoming in accrediting under the primary community healthcare standards, QIP is proud to be approved by the Commission as an accrediting agency under the new primary community healthcare standards. With over 25 years experience, QIP has developed streamlined systems and processes and a range of client-focused tools and resources to streamline the accreditation processes, decreasing the administrative burden often associated with accreditation. In addition, QIP's experience in community and human service sectors, QIP is part of the AgPal group of companies, which includes Australian General Practice Accreditation Limited. And AgPal is Australia's leading provider of general practice accreditation, which provides our team with comprehensive insight into the complexities of the primary care sector. This comprehensive experience combined with personalised support and user-friendly software systems allows us to better support service health and community services against the primary community healthcare standards. Now, we also have a number of, I mentioned, tools and resources available, so get in contact with us to find out more. And we also have a number of webinars coming up. So I've got the 7th of December, 8th of February 2024, and 7th of March next year, where we'll do a deep dive into the Clinical Governance Standard, partnering with Consumer Standard and the Clinical Safety Standards. So thank you again for all your time today. If you do ever have any questions that we haven't been able to answer today, or you just want to get in contact with us, the details are provided on the web screen now. Also, don't forget to follow us on our social media channels. As always, you can always reach us at www.qip.com.au to find out more information.